that running? Is that rolling?
now.
It is fantastic. Okay, guys.
Did you want me to
So,
sit here?
if you don't mind, if you just sit there, that's okay. Oh, okay, that's going back there. Okay, fantastic. Okay, so welcome, guys. So I'm Trishan, one of the clinical fellows here at the A&E. Can we just go around and get through names? I know I've met you guys on the shop floor anyway, but it's just for a interaction lesson. So if we just start that way.
Yeah, I'm Samrat.
Samrat.
I'm Alvin.
Alvin.
Annie. Joe.
Joe.
Robot.
Robot. Okay, thanks. I was apologies if I get your name halfway through that, because I'm mid-shift, you know, so I haven't had enough coffees yet. Okay, so we're going to be going through blood gas interpretation. The kind of, I'm sure you guys are familiar with ILOs, so let's just crack on through those. First of all, we're going to go through an approach to interpreting blood gas results. Now, has anyone actually interpreted the blood gas here before? Kind of, okay. Have you guys done it on the shop floor, or is this in your private study?
A bit of both.
A bit of both. Okay, private study. Okay, good. All right. And what we're going to do is we'll learn an approach to see sort of, you know, when you're in front of someone and you get quizzed by myself or, you know, like Prof. Carly or someone about a blood gas result, you can go through it with confidence. We'll go through an approach. Not a better one, but this is quite a reliable one. We'll also look at the causes of blood gas results. When you have deranged results, what are the underlying, you know, causes for them clinically? We'll look at the sort of definitions and causes of respiratory failure as well. We'll look for the definitions of them, and we'll look at the significance of the anion gap. I don't want to get too lost into that one, because to be honest with you, if I recall correctly from your curriculum, there's not too much spent on the anion gap. So it's kind of a bonus round, bless you. So we'll mainly be focusing on the first 3 ILOs. The format of this session is going to be that it's going to be a sort of slide-by-slide discussion of the cases. I want you just to, you know, be brave with your thoughts. There's no stupid questions. We'll just go through it. There's no stupid answers. And then at the end we'll have an MCQ quiz. We've got the websites loaded on our browsers. We've got the Wi-Fi ready to go, and our phones are charged, hopefully somewhat. Any questions about the what we want to do today? Okay, fantastic. So first of all, what I'd suggest you do is write down normal parameters, or be familiar with them. Okay, for a blood gas. So the ranges are on the right. In particular, you're going to find later on for the MCQs, you're going to want to know the normal reference values for CO2, bicarb, and the oxygen. Okay. I suppose the pH as well, really, the whole thing, the whole shebang. But if you want to take a picture of that, taking a picture of the slide might be a good idea, because then you have an approach for interpreting a blood gas. And what is that approach? First of all, what you want to do is have a look at it and determine, is the pH normal? Are we in a state of acidosis or alkalosis? And then you're going to move on to the respiratory component, as it's sometimes known, the carbon dioxide. Is that normal? Okay. And then you look into the quote-unquote metabolic component, which is the bicarbonate. And you look at these things, the respiratory and the metabolic components, and you say which matches the pH. So if you have an acidotic pH, i.e. a pH is less, that's less than 7.35, what's correlating with that? Have you got a high carbon dioxide, which is respiratory acidosis, or have you got a low bicarb, which maybe tells you it's a metabolic acidosis? Does that make sense? Okay, so once you've noticed what matches it, you look at what opposes it. So what opposes the pH and what matches the pH. So if you look at the bottom left, I've got a mnemonic there, Rome. So if you can imagine, looking purely as like numbers, if you've got a pH that's down, so you know pH that's like 7.2, it's a lower number than 7.35, isn't it? Basic maths. If that, then if the respiratory is going the opposite way, i.e. the carbon dioxide is high, then its correlation's opposite, isn't it? That means it's telling us a respiratory thing. But if you're looking at both numbers going in the same direction, so say you've got the pH going up, so it's like a 7.5, and you've got the bicarb going up as well, they're both moving in the same direction, that's telling you it's like a metabolic alkalosis. That's telling you the relationship between, like purely numerically between them. Does that make sense? That's one way people like to look at it, but personally I think breaking it down is to, like, if it's respiratory or metabolic and what matches with the pH is easier, but sometimes some people like to use that as a shortcut, which is why I popped it in there. If you find that confusing, I suggest you disregard it and just pay attention to steps 2 and 3 and direct to number 1. Does that make sense? Awesome. And then 6 is the O2 normal. Because it's all well and good interpreting a blood gas, but if your patient's there gasping for air, SATs of 82 or something, then you're going to be more worried about them being in respiratory failure, so arrest or something along those lines, than you wondering if they're having a PE or something. Okay, but also that gives you a clue as to whether the problem's respiratory. Is that okay? All right. Let's move on. So we've got the first case here, and what I'd like to do is I'm going to nominate someone to go through and interpret a blood gas. Okay? If you have any troubles, don't worry, we'll go through it together. All right. So case 1. These are the numbers. So what was it? So what? Samrat. Sorry, I knew I'd get it wrong. Apologies, that's me. Would you mind interpreting that for me, please?
So the pH shows acidosis. The carbon monoxide is raised, and the base axis is within normal, and also hypoxic. So respiratory acidosis and hypoxia, type 2 respiratory failure.
Okay. Do we agree? I'm getting yeses. Okay. All right. So I think you followed that well. Is the procedure we've kind of discussed. And what we've got here is a respiratory acidosis with hypoxia. Okay, so we talk about compensated sometimes, and just a bit of experience for me when I'm meeting some of your colleagues, I think there's a bit of confusion with compensation and that kind of things. So I'd be interested to see what your understanding is of it. When we talk about a compensated, let's say in this case, this is an uncompensated respiratory acidosis. What does that mean?
Probably something that's more acute, because kind of like the metabolic processes are caught up to.
When you say metabolic process, can you talk a bit more about the parameters there? Or
Okay.
What do you mean?
The bicarb is still within normal range, so
Yeah.
if it was to be compensated, I'd expect it to be raised to balance out the.
Absolutely. Then you expect something like partial compensation, and the pH is brought back to normal. Then you talk about complete kind of compensation. Does that make sense? Does anyone want me to go through that? Okay. Yeah, that's fantastic. And we've got hypoxia as well, because like we said before, don't forget that. That option. Okay. So these are the kind of causes for this. You're looking at kind of like obstructive cause, so your asthma, your COPD, or generally like mechanical, which is neuromuscular, structural kind of causes. Okay. So it's hypoxia, and it's the carbon dioxide slightly raised. What could you also call this?
Type 2 respiratory failure.
Spot on. Yeah, and particularly things like asthma and COPD, obstructive or mechanical causes cause this. What would a type 1 respiratory failure be?
Just hypoxia.
Yeah, basically. And we talk about the pathophysiology of it. What kind of is the general causes of that? Well, just name some causes of type 1 respiratory failure. Take a wild guess. COPD. Okay, potentially the acute phase, but I think asthma would probably be most likely. The reason being with asthma is that what happens is, if you can imagine type 2 is more like when they're getting tired, so they're having trouble exchanging, they're getting slowing down, low respiratory effort, and they're trapping in more carbon dioxide, so they're not blowing it off quite as much. But more acutely, you'd be blowing off carbon dioxide, and basically. You talk about VQ mismatch, so your PE is more likely to cause a type 1 and a type 2 failure. Okay, so that's kind of it really. If you can imagine, and your back pneumonias potentially as well. So it's more about failure of the ventilation perfusion being matched. Okay. More of a problem with the parenchyma, the actual functional units of it, to put it fancy. Right. And this is just consolidating what we talked about. Type 1, you're looking at a VQ mismatch. As you said, it's defined by hypoxia, but normal carbon dioxide levels. And we talked about it's acute alveolar hyperventilation, which is another beautifully fancy full term of putting it really. Okay. And we talked about type 2, alveolar hyperventilation, obstructive, neuromuscular, but also thinking of other reasons why one isn't maintaining a good respiratory effort, and that includes opiate overdosing. Is that okay? Moving on. Any questions? Good. All right. So looking at case 2. Right. Alvin, if you don't mind walking us through that one, please.
Well, he's alkalotic.
Mm-hmm.
His carbon dioxide is low. His bicarbonate is within normal range, and his oxygen is normal range as well.
Okay.
So he's in respiratory alkalosis.
Okay. Do we agree? Okay. Again, you follow the process really well. This is just straight up uncompensated respiratory alkalosis. Well done. Can we think of potential causes for this?
Just hyperventilating.
Hyperventilating. Hyperventilating. Okay. Anything else?
If the person is having like a panic attack or something, it might be blowing off a lot of CO2.
Yeah, very good. Okay. We'll talk about panic attacks now for a quick second because this is one little. Trying to think of what the word would be. You sometimes have MCQs. You have like certain pathognomonic things, things that are very theoretical and all that kind of thing. Well, I was actually reading about panic attacks because I'm a nerd, guess. And one thing I noticed in ED is when we have patients who come in and say they're querying like pneumothorax or chest pain, particularly younger patients, and they're having a panic attack. You conclude clinically diagnosed with exclusion most of the case. They have a panic attack. That they have hypocalcemia. Is anyone familiar with that at all? Okay, anyone seen that before? You will see it most likely if you do ED for even a short while. So what will happen is that you have a patient coming in and say they've got chest pains, they have palpitation, shortness of breath, and they have tingling, what's quite common, it's like peripheral paresthesia, that kind of thing. And then you do a bloods, that's as per your basic blood panel, they end up having a bone profile, they have a really, really low calcium. The reason for this, which I found out, it might impress some of the docs on the floor because some of them don't know. We were talking about COD, like, so I read up on it. So here's my cheat sheet. It's because you can imagine you have albumin. As you may be aware, this binds to hydrogen ions, and if one enters a state of respiratory alkalosis due to hyperventilation, i.e. panic attack, this causes the hydrogen ions to dissociate from that albumin and to compensate for that respiratory alkalosis. This allows the albumin to be freed up to bind to calcium. That's why you have a hypercalcemia. So that will resolve really spontaneously once they stop hyperventilating, once they calm down, and then that dissociation will reverse most likely. Okay, just a little golden nugget for you there. In the future, if you almost want to, I don't want to say diagnose a panic attack with a bone profile, but it's something that you will most likely look for. I only say that because I remember in F1 in A&E, I ended up having a basic bloods done on a guy who ended up having a panic attack, was very nervous, and then his calcium seemed to be very low. He ended up being called back into the department, and the consultant was just, why is this happening? Yeah, but there you go. We didn't refer him to medics and have calcium gluconate or anything. It's just that phenomenon there. But there you go. Maybe it'll appear up in a MCQ, and you'll know too much about it. Okay, so let's move on to the next one. Oh yes, so these are the causes. Another thing to consider is a salicylic overdose. Now that's quite interesting because you first of all get a respiratory alkalosis, and then subsequently that can become a metabolic acidosis. If that makes any sense. It's just to do with the this I don't know a great deal about, but it's kind of a similar mechanism as before in terms of dissociation and everything, but of hydrogen. But it's just, I think it's to do with the actual molecular structure and maybe metabolites of that kind. I'm not entirely sure, but that's just something you'll probably again see in MCQs. Okay, case 3. Ah, no. Okay, so this will be nice and easy. Joe, why don't you tell us what that is?
Okay,
Step by step.
Start with these antibiotics.
Yeah.
So quite a little bit more than another one.
Yeah, it's a bit specific.
The oxygen is okay. CO2 is okay as well, and the bicarbonate is a little bit low.
So why don't you tell us what it is?
Uncompensated metabolic.
Very good. Okay. All right then. So again, you followed the process really well there. To be honest, that's what it's about. It's not about necessarily getting the answer, although you did. But you followed the process, which is really good. Can we think of causes for a metabolic acidosis?
Sepsis.
Sepsis, very good. Because you can get like lactic acid being produced, can't you? So that's gonna
AKI.
AKI.
Is that?
That's an interesting one. Can it cause it? Explain to me how it causes it.
Does it cause that? I don't know.
Okay, I know CKD. You know, I'm gonna be honest. I'm not gonna poo-poo that idea because I'm not convinced. Although I'm not sure. I'm gonna say potentially because what can happen in AKI is you get high urea. So I know CKD is the cause of metabolic acidosis because you get a uremia that forms uric acid. That can lower it. Suppose what could happen in AKI is you're going to have a high urea, don't you, acutely, and that's usually underpinning. I'm going to say yeah, basically, because what happens is what happens in AKI, essentially. What is AKI?
Dehydration.
No, what is AKI?
Creatinine level on.
What does it stand for?
Acute kidney
Kidney
injury.
injury. Yeah, acute kidney injury. Yeah, and what's it usually caused by?
Blood flow to the kidneys.
Yeah, so hyperperfusion, which is usually due to what kind of conditions?
Sepsis.
Sepsis, yeah. So that's why I also say it's probably going to be implicated because sepsis, renal stenosis.
Is that?
Yeah, yeah. It's not AKI. Maybe you could get an AKI on CKD, but yeah, you're quite right. It's going to reduce perfusion. I suppose if you can get. Also, if you have a renal artery stenosis and then you take a ACE inhibitor, can't you? You get like a flash pulmonary edema. Pretty well. That's another MCQ question. Yeah, you come in very short of breath, florid chest sign, just been tried on an ACE inhibitor. Yeah, so very well. Anyway, we're talking about the pathophysiology here. We're talking about hyperperfusion. If you can't get blood flow to your kidneys, i.e. AKI, you've probably not got good perfusion. So your lactate's probably be quite high. So yeah, I'm gonna give you that mark. Okay. So I'm quite happy with that. Yeah, those are the lactic acidosis is referring to the sepsis because that is okay. Anion gap. So this is how you calculate an ion gap. It's basically the most common, or one of the most common positive ions in the blood, which is sodium, and then you're balancing that against the negative ions, i.e. the chloride and the bicarb. Is that all right? Okay, let's see what we got. Okay, so this is really to help you kind of, we start to extrapolate, causes of a metabolic acidosis to a certain extent. So if you're looking at, if we calculate the anion gap with the sodium, bicarb, potassium based on the, the sodium, bicarb, and the chloride based on what you've got on the blood gas, then if you look at this raised, it's elevated, then that's telling you a process which is producing these anions essentially. Anion, is that positive or negative?
Negative.
It's negative, yeah. So there we go. And then we're looking at lactic acidosis, DKA. So you're looking at a process that's just churning out, like acid essentially. And if you look at decreased bicarb, that's what if it's normal 3 to 11. It can be 3 to 20, depends what reference ranges you use in the labs, but 3 to 11 is a pretty safe bet. Then you're looking at sort of things that are using up that bicarb or causing loss of bicarb, in which case that would be a GI losses and diarrhea, and also renal tubular acidosis. And then obviously, if it's low, then you look at things like hypoalbuminemia, which is causing a compensatory rise in chloride and bicarb. Does that make sense? Okay, well, like I said, this is bonus points. I'd say if you can understand the high ionic gap, if you have to remember just that left third of the table, that's useful. The rest of it, look at general courses. Any questions about that? Okay, good.
What's RCA stand for?
RTA, that's renal tubular acidosis. That's when you have a condition you sometimes find, say, due to like medications. I'm not sure if AKI can produce that actually, but usually it's to do with problems with the renal tubules where like it can't reabsorb bicarb, or there's a problem to the regulation of like bicarb movement between that and hydrogen ions as well. It's basically a problem of like exchange of substances across the tubes. and you have renal tubular acidosis.
Yeah.
There's like four different types. It's quite a rare thing. And mud piles refers to additional processes which produce acid, and so you have a high anion gap. So mud piles, you've got your methanol. It's just like methanol and propylene, ethylene glycol. These are things which you might see below associated on a class. So maybe those with no fixed abodes trying to make their own kind of alcohol, homebrew, so to speak, drinking like brain freeze, that kind of thing. So antifreeze. Not drinking brain freeze. Drinking lots of ice cream now. No, antifreeze, sorry. Uremia is what we discussed before, and this is why I want to give you a point with AKI potentially. That's the underpinning reason. DKA obviously. Infection, which we talked about with sepsis, lactic acidosis, again related to that. And salicylates, like I said, you get respiratory alkalosis and metabolic acidosis. Has everyone got that jotted down? That? Okay. Any questions about any of that? Very good. I know what we're going through is pretty dry, but it's, if you can understand this, then you're going to be over the hill when it comes to blood gas interpretation. Sorry, did you see anything? Alvin, did you get all that?
I'll just go for it.
Okay, sorry, no, we're on a rush.
That's it.
Okay. Next blood gas. Who wants to take this one?
Yeah, sure.
Yeah, go for it. Go and stew out some.
So the pH is high, indicating an alkalosis.
Indeed.
The oxygen and the carbon dioxide is normal,
Yeah.
just about. I think the patient isn't hypoxic, but the bicarb is really raised at 35.
So, you can go.
So is it a metabolic alkalosis?
Yes. I should have asked everyone's opinion first. But there we go. And I'm just going to go through the causes for this one because it could be confusing. Vomiting. Why does vomiting cause metabolic alkalosis?
You're throwing acid out of your body.
Yeah, you're losing HCl. So as a result of that, you're getting more HCO3 or bicarb in your system, which is alkalotic. And then NG tube drainage, kind of the same thing because you've got you're aspirating like gastric juices with that. Those are generally the causes of it. Really. Okay. So it's not something you see all that commonly. I suppose in acute surgical conditions like a bowel obstruction or something like that, you might see persistent vomiting and then that'll watch them to such. Okay. Fab. Moving on. Okie dokie. So, thanks for bearing with us. Let's crack on to the more interactive segment. I think we come to a consensus that we're going to be competing, aren't we? So, let me see.
Do you guys use this in school as well?
Yeah.
Really?
We never use it. No.
Yeah,
I saw a post on Facebook.
my school don't use it. But then I came to uni and then in the lectures they use it. Everyone's like, oh, we used to use this so much in school. I was like,
We used it in college for some reason.
There's a weird group where they posted random ones that were going on live in classes across the UK.
Oh,
So
really?
random people from the UK would just join them.
Okay. Now, I'll be honest with you, it's my first time using it with a group. I've obviously tested it, but we'll see how this goes. Is everyone on Kahoot? If you go on the Google, it should be the first link. It's I think it's kahoot.it or something like that. Is everyone on there ready to put a game pin in? All right, let's give this a whirl then. Okay. So player versus player. Okay, so pin number is 150422. So that's 150422. Has everyone popped that in? Very good. So we've got above. Samrat's in the house. Eno, very good. How we know? And is Joe gonna stand up?
Should be in there.
Yeah, I think basically it's not going to appear on the screen. It's just going to appear on this. So you okay? It's 150422.
Yeah, just checking the nickname.
Is it to check that it's not expletive or something? Not obscene. Okay. Let's have a look. Okay, so do you guys want to do this with the screen, or do you want me to just show you the phone? It's up to you. Because we can put it on the screen if you want to, see when everyone's answering, a bit more live time. But it means just putting another game pin, or do you want to crack on with it on the phone? I don't mind.
Carry on.
Carry on.
Carry on,
Okay,
yeah.
fair enough. All right. Without further ado, just 8 quick questions, and we'll get into repetition. Okay, it's a quick one.
Why is it like that?
Where can
What
we
do
see
we
the
do?
question?
Yeah.
Well, you just see it.
I
which
feel
is
we'll have to
options.
have it on the screen because we just get
Okay,
options.
alright, here we go. We knew there'd be technical difficulties, so let's just get out of that one. It's on my screen, but it's not on yours.
Okay.
I don't know why that's the case.
I think you can, if you load it on that.
We will,
and then
okay.
just
Apologies,
turn it
guys.
on.
This is why we went out for a little bit extra time. Okay. But I do apologise for that.
It's like, do I just pick my
It's
favorite
distracted,
shape?
though.
Yeah,
You
just-
know?
Also, yeah,
That's
exactly.
like,
Alright.
What are you-
hungry.
Are you hungry?
Yeah.
You guys not eating today?
I will go and have something to eat
Are you
after
not
this.
like dreading the fact that you've got it tomorrow when everyone else has had it today?
Worried.
Not worried, but just like
No, I was worried on Monday, but since then I have
calm yourself.
yeah, I've done some mindfulness activities. Calm myself down.
Some headspace.
I like finally
Yeah, some
understood what
headspace.
mindfulness is. Apparently it's like you acknowledge the worry, but be like, I'll deal with this later.
Are you doing a bit of CBT on yourself?
We used
Yeah,
to
I
thought
actually did
buses
that.
and letting like
Fair enough,
Is that
mindfulness.
not just a bad coping strategy? You worry,
No, it's
feel
called
like-
mindfulness, it's
We-
NHS approved.
we used
Oh,
to
cool.
have
You can
thought
go on this like
buses.
thing
So
on the
that's-
University of Manchester Counselling and you can actually do CBT on yourself. It's
wow.
like a free online course, which I haven't done, but like I did look into it.
There's absolutely no shame. No?
You'd rather do that. Trying to get an appointment with like
Yes.
counselling, uni counselling.
No,
is
I feel like
Right.
my
Yeah.
problems are just like laziness and like that's not a reason to go to a counsellor.
There's a fine line between laziness and depression.
It's not depression.
No,
It's
No, I
like
feel
no
like-
effective.
Have
I
you been
feel like
feeling
the counselling
unmotivated
service
for a long
is
time?
really, really like
No, just about 3 months.
See, this is the thing.
Really? Tell me a bit more about that.
Is it
Yeah,
laziness
it can be
or
a sign
are you
that
actually-
you're
Sign
stressed.
number 1.
I think it's a sign of low vitamin D.
Why?
My mother
You
thinks
know,
so.
You sound like every patient in GP.
Yeah.
You know, things
No, my
like
mother
low
said that. It's
vitamin
like,
D.
oh, I take vitamin D tablets, and your dad is also now on them. Like, you
But
feel
so
tired.
is half
So
of Manchester and
I know.
every like.
with this skin, like going outside is not gonna do me anything in February. I am outside.
Shame.
Was that rude earlier?
Pardon?
Did you think I was rude earlier? Was it kind of funny?
No, I just feel like we should all
Considering,
turn up to it.
No,
I wouldn't
Yeah.
have said it first.
Andy,
Yeah.
considering like what I told you about my email exchange, like I thought it was pretty bold to like.
Yeah.
Yeah,
That
ask
out.
It was
Yeah.
bold.
Considering I got called unprofessional.
Unprofessional.
Oh, here we go. Okay, guys, the new pin is 174258.
Oh.
174.
258. I'm going to pop on that screen now, okay?
174. Didn't I do
The dabbing.
No,
Damn,
Fiona will do
she
that
did
in like
four
3 years'
dances
time.
right now.
Oh.
Imagine, yeah. Actually.
Awesome. You ready? Without further ado. Is the music alright? Do you want me to switch it off? You good?
No.
Alright,
What's
excellent.
Nice.
Alright. Do your best. Okay, and then select on your phones.
Oh, well, I didn't see that.
Oh,
It's
my
a-
right,
God.
it's at the top.
Oh, wait, okay.
Oh, fuck it.
Very good.
What
Okay.
a guess. What a guess.
Alright, so what we'll do is we'll focus on questions that maybe we didn't get right, okay? And we're not going to go through each one. Okay.
I think I pressed the right one.
Okay, so do you understand that one?
Mhm.
Anxiety, we talked about that,
Mhm.
and we talked about why that isn't as cause of type 2 respiratory. Very good. Okay. Here we go.
Oh, wait.
Oh no.
Do we
I put
understand
acid
this?
in it.
Do we
Oh, look.
Yeah.
Okay, we sure? Okay.
Yeah, I just like read it wrong. I thought respiratory alkalosis in my head and then put down the.
Good,
Yeah.
because you said, you know, the carbon dioxide lower and feel that. Okay. Yeah, the it's got low carbon dioxide, the bicarb's fine. Okay. Alright, we've got shifting leadership here. Okay.
Oh.
Oh, no.
What? I don't even understand. Oh no! Oh!
Oh, I think I put the wrong one for this one as well. Yeah, I put the wrong one.
Okay, guys,
Oh.
it's carbon monoxide. We went through how the other ones are. Your pain would cause potentially hyperventilation in a distressed patient. It's carbon monoxide poisoning. I'm happy with that one.
Yeah.
It's just going to cause hyperventilation.
Yeah.
Okay.
Late front.
I'm
Alright.
keeping up.
You guys are all doing very well. Impressed. It's getting a bit trickier. Okay, why is it that? Why is it persistent vomiting? Okay, interpret the gas. What is it?
Metabolic alcohol.
Very good. And so why do we think it's persistent vomiting? Yeah, it's because you're vomiting up the hydrochloric acid, so you lost using that. All right, very good.
Isn't the bicarb also within normal range?
28.
Oh, okay.
I don't know why I'm telling you that.
It's good that you know now, though. All right. Okay, here you go.
no, it's very wrong.
Ah.
Okay, so I put this in because this is a very common trope in blood gas. This is like one of those memes, really, you know, about like the chronic. Oh, they don't need to have oxygen. You know, they're on 88 to 92%. Do you guys know about that?
Yeah.
There are some patients who you got to be careful with when it comes to oxygen titration, and those are the chronic COPD patients. What is that blood gas telling us?
So it's compensated, but the
Assuming it's an ABG as well. Can't put that in.
compensated, but CO2 is still high, so it's probably not able to breathe as much, but the compensation anyway.
Spot on, Joe. Yeah, the fact that the bicarb is changed is telling us this isn't an acute issue. Okay, you have plenty of time for the kidneys to work with some bicarb reabsorption to occur to try and bring that pH closer to normal. Now, it might well be that the pH isn't normal, but it's there's still that kind of compensation. So why is it in these patient lists who show evidence of chronic COPD, why is it you want to be careful with giving them oxygen?
So you rely on hypoxic drug.
Exactly. What was it?
Hypoxic brine.
Yeah, so you both said that. We want hypoxic drive. Okay, because what other drives do we usually have that are intact, provided you don't have?
Hypocarbon.
Yeah.
Is it hypo? Yeah.
Hypocapnic. Yeah, very good. So, yeah, smokers, are so used to maybe retaining carbon dioxide due to the processes, things like the kind of emphysema, bronchitis kind of pictures that they occur generally. So they're used to having chronic CO2 retention, is what it's called. It's kind of what she asked for, isn't it? So because of that, you don't want to obliterate their respiratory drive, only remaining always hypoxic by giving too much oxygen. Spot on. All right. Very impressive. Okay. All right, sorted. All right, guys. So learning points. We learned a little bit about compensation there, about chronic COPD from the questions, and I think it's just lungs alkalosis, metabolic alkalosis, probably the ones we've had a bit of trouble getting through. So I'll say learn the reference ranges for bicarb in particular. Okay. I hope you guys enjoyed that. Anyway, to an extent, I appreciate it. Can I hand you guys?
And
Can
thank you.
I hand you guys
for
the
last
feedback sheet?
minute.
If that's okay.
I'm not the last telling what you are.
But I got the last one right.
I got it as well, I got it quicker.
Oh, that's unfair.
And then if you put it face down and make a pile, keep it anonymous. That'd be good. Alright, is there
No,
another?
is it not
Oh, we
mine?
meant to write down your name.
Yeah.
My name.
Okay, I wrote my name.
It's alright. It's not a big deal. I'll accept any feedback gracefully, and if you're grateful to it.
What's the date?
It's the 13th, I think. Is there any questions about that session? Anything that needs clearing up? No? Cool. Alright.
Is the anion gap, is that only for kind of like...
Usually metabolic acidosis, isn't it?
And what does key educational outcomes mean? Like, as in what I
The
learned?
ILOs, yeah.
Oh.
What did you learn from that?
Okay.
And what you could do for me, which would be really helpful, is that obviously the ILOs, which I never to bring it up. Let's go back to the ILOs. Can you tell me which ones, if any, you felt weren't achieved or you found difficult to achieve? If that makes sense. If you and just tell me what you like covered more. I'd really appreciate that one.
Okay, so which ones weren't covered so well?
Yeah, maybe which ones weren't covered so well, which ones you found trouble with, and the ones that you felt maybe weren't covered as well. Sort of why maybe it was a bit rushed, or maybe I didn't go for enough depth, or maybe I was waffling on for too much. It's At the end of the day, these are all very important outcomes. Maybe the anion gap, like I say, maybe academic, but you are academic. So. So are you guys, anyone done for the day?
Yeah.
Good. So you had your Oski this morning?
Yeah, I didn't this morning.
Oh, okay. Yeah, went okay?
Well, I did a roll look. I woke up at 5 to 10. We were supposed to be there for 10. So I made it in for 7 minutes. They were alright with that.
Okay. Alright.
How did you manage to do that in 13 minutes?
Yeah, you got
Also, I literally woke up. I was like, oh my god, what is happening? I thought I was doing Uber, then got ready whilst the Uber was arriving.
Jeez.
It was
that's what happened
horrendous.
to you a lot
You
recently.
don't know how
Yeah,
to
you
do
do.
that.
Oh,
Was it
man.
you that got an Uber in and then like, didn't get signed in anyway? That was awful.
Yeah,
Uber and
a
laughing
minute
at me.
late.
They were absolutely laughing at me.
Oh, fair.
As is.
You weren't like, I don't know, as long as you're resting alright, you know, you just...
Yeah, no, it was
stuff.
like I got to bed early.
Yeah.
Don't know what happened.
Oh, dear.
Set my alarm and everything.
Well, at least you got the sleep you needed, yeah?
Yeah, it went alright.
What time did you finish if you started at 10?
1.
1. So what you cycled 3 or 4?
4.
4, okay. So I'll finish by 1 as well.
Are you in 4 or 3? Oh, yeah, that's good because you only have to wait for like 15 minutes afterwards as well.
After?
You only
But
have
I
to wait.
probably have to wait loads before.
No.
Yeah,
Depends
you
on
do a
the-
bit. You probably have to wait for like half an hour before. But at least you can revise then. You're not just sat there without your
I
phone.
would have to take my revision material there. It's kind of
I'm
embarrassing
so
when everyone has
ill.
like really nice neatness and mine just like
Guess
pencil
you're not getting
scribbles
signed up.
everywhere.
Guess you're not getting signed
Like,
up.
I don't know what to do because I'll just turn up and
Just,
suffer all
just see
day.
how you feel in the morning. If
Yeah.
you're too ill to come, you're too ill to come.
Never stop slacking.
Stop slacking. I want to pass them.
Can
What
we
do you
stop
want
the
to pass
video now?
them? Is this
Yeah,
still
yeah,
recording?
Yeah,
Yeah.
Robab, can you stop
Oh, yeah.
the video
Thank
behind
you very
you?
much.
Oh.
It's okay. How would you like
Yeah,
me to